Hello, good afternoon, good morning for those joining us stateside, and welcome to this pre-meeting session ahead of our annual meeting of the Coalition for Operational Research on Neglected Tropical Diseases, or COR-NTD. I'd like to give a brief overview of what COR-NTD is and how today's meeting fits into the bigger picture, but first, just a little bit of housekeeping. My name is Chelsea Toledo. I am the Associate Director of Communications and Development for the COR-NTD Secretariat. If your name is also appearing as Chelsea Toledo in the participants list, I do apologize for that technical glitch. And we would just ask you in the participants panel to click more and rename so that we know who is joining us. Thank you. But before we launch into our session, I want to give a big thank you to the STH Coalition and Evidence Action, along with all the speakers and moderators for this session for their incredible work to organize this event. I'd like to give special recognition as well to Dr. Susie Campbell, who, although she couldn't be here today, worked very hard to conceptualize this session. So for those of you who are new to this space, COR-NTD is a group of researchers, program implementers, and their in-country partners with the shared goal of optimizing NTD control and elimination. Its secretariat is the Neglected Tropical Diseases Support Center at the Task Force for Global Health, funded primarily through grants from the Bill and Melinda Gates Foundation, from USAID, and from UK Aid from the British people. COR-NTD meets annually in conjunction with the American Society of Tropical Medicine and Hygiene meeting, or ASTMH. The purpose of the COR-NTD meeting is to identify knowledge gaps and next steps for operational research on NTD. This year, like ASTMH, we did have to make the difficult decision to move our meeting into a virtual space. So while meeting with our partners is our favorite time of the year, we're trying to make the most of our new virtual life and adapt our meeting accordingly. And that's what brings us here today. One of the silver linings of going virtual is that we're not as constrained as we normally would be by time and space. Therefore, we are able to have greater representation, both in terms of content and in terms of participants. In the content we are able to showcase in the context of the COR-NTD meeting. So this session type that we are having today is allowing conversations to build upon one another leading up to and during the meeting. Today's session represents one of 3 sessions on the operational research necessary to meet the goals for soil-transmitted helminthiasis. After today's session, we'll host one more on this topic. Then at COR-NTD in November, the 3 groups will come together to have a joint meeting and discussion. So while this is a bit of an experiment, we expect that the outcome will be an even more developed operational research agenda than we've already come to expect from this excellent group. We're excited to continue with the experiment and thank you for being a part of it. So with that, I'd like to introduce our moderator for today's session, Donald Bundy. Don is a professor of epidemiology and development at the London School of Hygiene and Tropical Medicine. He worked for more than 30 years in the role of school health and nutrition programs and development for school-aged children and adolescents, especially in poor countries. He currently serves as senior advisor to the World Food Program in Rome and also advises the Children's Investment Fund Foundation in London, the World Bank in Washington, D.C., and several national governments. With that, I'll hand it over to Don to explain today's session. Thank you.
Great, thank you so much, Chelsea, and thanks indeed to the whole COR-NTD team for making this possible. While I'm doing the early thanks here, I'd like to particularly highlight Susie Campbell's contribution in conceptualizing this event, which I hope will be exciting and informative about one of the greatest, one of the largest deworming programs in the world. And I'd like to, it's a shame that Susie can't be with us, but I'd like to thank Mark Minery and Shrabani Nath for stepping in and putting so much effort into the organization. Also, we wouldn't be here at all if it wasn't for the work of Dr. Ajay Khera in driving this program forward in the first instance. He was the Commissioner for Children and Nutrition in the Ministry of Health and Family Welfare in India, and retired earlier this year from that job, not from the public health arena, and his work was absolutely seminal to the development of this program. I've had the opportunity of working with the Indian government and with Indian academic colleagues and Indian academic institutions for more than 3 decades. So I was really delighted and honored when I was asked to help introduce this set of sessions. This is very much an India program, and what's wonderful about this opportunity is that because of the virtual connectivity, we can really hear from the people who are most directly involved in it. India, as you know, is a country of superlatives, starting with its ancient history and its vast cultural connections, but it's also a country with superlatives of scale, one of the most populous countries in the world. And we have the opportunity today to talk about what is one of the largest national public health programs, certainly the largest in the world, that delivers on a single day, and that's the National Deworming Day program of India. And it's such a huge program because it seeks to treat all at-risk children in India, delivering treatments through schools and through preschool, Anganwadis and related structures. It's a Government of India program run by the Ministry of Health and Family Welfare. And it's a program which started in 2015. Actually, it started sometime before that in its operational research phases. But in 2015, it was really consolidated and launched as a national program. And today, it reaches around 275 million children annually. I'll say that again, 275 million children annually. And despite that, it is primarily a domestic program, domestically funded program, relying on the procurement of albendazole domestically for most of its supply. Today, we're going to hear about how this program is beginning to show impact and how research has contributed to that. We're going to hear about how the government has set up a high-level scientific committee to chart a roadmap for the program going forward. I have the honor to be on that committee, but I'm very delighted that we have with us other members participating today who are actually the direct instruments. They've been instrumental in driving this program forward. So I particularly want to, we will be hearing from 4 panelists, starting with Dr. Sheila Deb, who is the additional Commissioner for Health for Children and Nutrition in the Ministry of Health and Family Welfare, and who leads this program and will be talking about the history and the structure of this extraordinary working at scale. We'll then hear from Dr. Agarwal, the Director of Epidemiology at the National Centre for Disease Control, who has undertaken an all-India mapping of STH. And then from Dr. Manoj Murkata, who is the Director of the National Institute of Epidemiology, an extraordinarily successful institute in India, and he has been leading on the impact evaluation. And finally, we'll hear from Ms. Priya Jha, who is the India Country Director for Evidence Action, a major technical partner for the Government of India in running this program. And after we've gone through all of that, we hope we will end with a discussion. And I'm hoping some of you will put some questions into the chat system so that we can try and answer some of them. So that's it for now. I can see that Dr. Deb is ready to make her presentation. And so Dr. Deb, if you'd like to start with your presentation describing the program as a whole. Thank you.
For my presentation. And first of all, I thank the COR-NTD secretariat for giving me the opportunity to present this on behalf of the Government of India on this National Deworming Day program. As you have very nicely, excellently, you have briefed just now. So, and I thank Susie and Donald both for taking this vigorous effort for making it possible, this, and also Chelsea. So now I'm going to present on the development of the Government of India's 5-year stage control roadmap. So as you are aware, WHO has identified India as a high burden country for STH infections, and the WHO predictive map shows that 50% of the country's prevalence of soil transmitted helminths, 50% of this country, they are suffering from more than 50% of the prevalence for the STH infections. And so if we look into the journey of the program, in 2009, actually, a brief guidance was sent by the federal government to the states and union territories on STH control activities. However, there was no systematic implementation strategy defined. In 2014, uh, there was introduction of the 100-day agenda for health ministry, and in that 100-day agenda, the school and Anganwadi-based deworming was included. This paved way for development of detailed operational guidelines. In 2015, based on the lessons learned from the successful polio program, another flagship program of Government of India, so this National Deworming Day program was conceptualized as a fixed single day strategy, and it is incorporated all the successful strategies of polio program like mass media campaign, quality preparedness, adverse event response, and a robust monitoring and supervision system. And it was launched in August 2015. And it actually is a unique convergence strategy. It involves other line ministries for program implementation, using the schools and the Anganwadis as service delivery platforms. And for the implementation of NDD, the Government of India and the state governments work together to commit domestic resources for consistent and timely program implementation. And the National Center for Disease Control was entrusted with the job of doing the prevalence survey, baseline prevalence survey, because the government was interested in implementation of evidence-based program. So the data was generated through this baseline STS prevalence survey within 2016, and it helped in making the decision making, and which further facilitated rapid scale up of the program. So, as you are aware, so within 5 years, this National Deworming Day program has become the largest fixed single-day deworming program in the world, reaching around 260 million children 1 to 19 years age. As Donald has just now said, that it is around covering around 275 million children. So, the objective of this NTD was to control STS infections by administering a deworming drug, that is albendazole, to children of 1 to 19 years age with consistent coverage of more than 75%. So the strategy includes biannual rounds of deworming with fixed day approach, that is on 10th of February and 10th of August each year, that is around 6 months apart. And the teachers administer albendazole to all school enrolled children aged 6 to 19 years at the schools. The Anganwadi workers administer albendazole to all children aged 1 to 5 years and out of school children aged 6 to 19 years at the Anganwadis. And the unregistered and non-enrolled children are mobilized to the nearest Anganwadi center for deworming by the ASHAs. They are the community-based health workers. Children who are sick or on if they are on medication, they are not administered this tablet. These children are advised to have albendazole upon recovery, and we actually also plan a mop-up day. Usually it happens a week after the NDD. So children who could not be administered on NDD, they are administered the tablet on the mop-up day. So here you can see the journey so far by NDD. So as I have said, in 2015 it was launched, 11 states participated, and 89.8 million children and adolescents were administered albendazole on that occasion for the first time. And then uh, over the years, you can see that coverage and targets and coverage are consistently increased. And you can see that in 2019, 2018 and 19, we got around 255.6 million children covered during the August round, and around 260 million children covered during the February rounds in 2017 and 18. So here is the scale of scale of improving the coverage over this for only 4 to 5 years. In 2020, in February round, there was obviously a very low coverage compared to the previous rounds. It was 111.23 million children could be covered. As you are aware that due to COVID pandemic, there was national shutdown, nationwide shutdown of these non-essential services. And so, and there was also problem in supply chain management during that period. So there was a low coverage. So achievements, the other achievements are like, as I have already said, in 2015-16, all the baseline STS prevalence survey was completed by NCDC. And then 2016 only, the NDD app was launched in February. In 2017, the government of India, another program had the Swachh Bharat Mission program. That platform was leveraged for disseminating NDD messages. In 2019-20, the stakeholder base was broadened to include the technical colleges, nursing colleges, and integrated child protection schemes, labor and urban development to improve coverage of the adolescent children there. So here are some points of how the NDD program could scale up, because this was because of this consistent implementation of the NDD rounds since the inception in 2015, with high level of leadership and commitment by the federal and the state governments. And the annual budgetary allocation by the federal government also increased progressively. In 2019-20 financial year, the budget allocation was around $23.5 million. For this was a dedicated budget for Deworming program, and this was an increase of 4% from the last financial year. So steadily the budget allocation is also increasing, and there is also improved target setting. Because earlier the states used to set up their targets as per their convenience, but now with consistent advocacy, they are actually targeting for the census population. Then there is a strategy for inclusion of private schools and out-of-school children by all the states, as I have already mentioned. And the evidence-based deworming is also being encouraged through follow-up of prevalence surveys. And these follow-up prevalence surveys are continuing till now. And this is to determine the treatment frequency now. And then the domestic drug procurement, that is another important strong pillar for the program. Government allocates around 10.5 million yearly for the in-country procurement of albendazole. And in the first 4 rounds, 85% of the drugs that were procured were locally procured, and the 15% were donated by the WHO from the WHO free drug donation program. So on the right side, you can see that there is a steady increase in the coverage against the census target over this last 5 years. So now you can have an idea of the target setting and coverage trend in the private school children. As I have already said that later on in 2016, this the federal government planned to initiate this private school strategy. And so here you can see there is a fluctuation in the total target and the coverage, because it depends on the number of NTD implementing states. Especially there are two states, Madhya Pradesh and Rajasthan. They conduct annual deworming round because of their lower prevalence. And so whenever in which round they are joining this NTD, on that round the total coverage increases. Actually, targets also increases, coverage also increases. So, and there is also engagement with the private school associations, and this has been done for increasing coverage. And it has since 2018, urban settings have also been encouraged to participate in the NDD implementation strategy. For out of school children, the target setting and coverage trend. So here you can see also the similar trend. So this in 2016 only, this out of school inclusion strategy for NDD was adopted. And ASHAs, as I have said, that they are the accredited social health activists. They are the incentivized workers, not the salaried workers. So their engagement was strengthened to mobilize these out of school children and adolescents to the Anganwadi centers for deworming program. And there is also a focused data-driven advocacy for the census-based target setting. And this is being done every year before the NDD round. And the state program managers, they are actually called in a meeting at the national level for review and orientation of this NDD program. So, and there every year we are twice, we are advocate them for this focused data-driven program, so to improve the census target. So this 5-year program from 2015 to 2020, if you measure the impacts of NDD on stage control, so government has been effectively executing this program across the India to ensure that the worms are no longer a public health threat. And since launch, the coverage over the 5 years have increased around threefold across the states. And overall program coverage has increased around twofold in government and private schools and out of school children. And program has been institutionalized through mobilization of sufficient funds from domestic resources. And there has been an inclusion of the dissolution criteria for albendazole in the monograph, so that as it has been mandated by the Indian Pharmacopoeia, and this for drug procurement, it has now been mandated that it has to be the criteria has to be fulfilled. Baseline and follow-up prevalence surveys, these have been conducted by the NCDC and the evidence action on a state-by-state basis, and it shows that there is widespread reductions in stage prevalence in the states, and both in total in prevalence as well as in intensity. And this has happened. We presume that due to this consistent high quality implementation of the program. Though it is difficult to assign the impact solely to deworming, as the socio-economic factors and the water sanitation and hygiene improvements, they may also play a role. And now I am giving some examples, like the prevalence reduction in Chhattisgarh. From 2015, it was 74.6%. So it has come down to 13.9% in 2018. And there is also a differential prevalence reduction by the parasite species, such as among the school-age children, the reduction from 70.4% in 2015 to 13.7% in 2018 is due to 80.5% reduction of Ascaris lamblycoides infection in this cohort of 5 to 10 years. So this is an encouraging fact for us, for the program managers. So now we are thinking about the strategy for NDD beyond 2020. So NDD, since its launch in 2015, it continues to reach a vast number of preschool and school age children. And now we have comprehensive baseline stage prevalence and intensity data available with us. It is of 2016, and we also have the follow-up the survey data in 2019. So these are for the 14 states and UTs till now. For the others, by 2020, we plan to complete this survey, but due to this COVID-19 pandemic, it has been delayed. So now it is critical for us to review and use the recent prevalence and program performance data to determine the treatment frequency in the states for the upcoming years for guiding the stage control efforts of our country. As Dr. Bandi has already said about the high-level scientific committee, and this has been set up with the national and the global experts. And this is the purpose of this committee is to complement the leadership of NCDC task force in order to develop the stage roadmap and to address the key research and operational questions. So the strategy beyond 2020, what we think it will be to guide it should have guidance on the program continuity, on impact assessment surveys, and revisions of the treatment frequency as well as the surveillance systems. So as way forward, we think that this continuation of this high quality NDD program is crucial to sustaining progress towards the goal of elimination of STH as a public health problem in our country. So it is critical to implement the consistent NDD rounds as per the currently available treatment guidance. So with additional follow-up prevalence data, which we expect to be available in the coming year from the rest of the states, we presume that there will be need for revisions in our in this treatment strategy or treatment frequency, looking into the already obtained results, which shows a drastic reduction in many of in the stage prevalence in many of the states. So we also we hope that we will be able to provide high quality messaging through the IEC and BCC activities, and the community mobilization will be also need to be enhanced to help this sustaining this program gains. And there is also emphasis on implementing evidence-based approaches and strategies for STH control efforts. So regarding setting of this high-level scientific committee, with approval from Ministry of Health, Government of India, this high-level scientific committee was on STH was set up in September 2017, and this committee is chaired by Ministry of Health, and evidence action serves as a secretariat, and its role is to provide technical advice and information on globally recognized strategies and develop STH roadmap for Government of India. 8 to 9 participants are there, including national and international research and epidemiology experts. And WHO representative is also there in this committee, along with representative from National Center of Disease Control. So the 7 key thematic areas have been identified by HLSC. First of all, to strengthen monitoring and surveillance strategy to track epidemiological progress and provide technical guidance on the goal of elimination as a public health problem. Then increased coordination with the lymphatic filariasis program. This is now the need of the hour. Then increased coordination with WASH partners, emphasizing STH control. Document and publish successes of what is being achieved with STH control in India. Anti-helminthic access, efficacy, quality assurance, and managing supply chain changes, and improving treatments among women of reproductive age group. This is a big age group, and we have not yet started the program, but it is also need of the hour to start the program in this women of reproductive age group. Then responding to the changing technical and program landscape. So here I present some key operational questions from the Government of India for this STH roadmap. So for the future deworming strategy, we are facing these questions which need to be answered for developing a comprehensive and effective STH roadmap. So first of all, how India can address the need for technical support to an increasingly diversified state and sub-state prevalence landscape while maintaining cost effectiveness and optimal treatment frequency. Second, what is the best strategy to facilitate integration with other sectors to drive elimination, such as with WASH and lymphatic filariasis program? Third, whether India should start the process of addressing the issue of potential resurgence at this stage of the program. And last but not the least, is there if there should be any plan for initiating surveillance system. So thank you all for a patient hearing. I'm ready for any questions if there is query from your side. Thank you.
So thank you very much indeed, Dr. Deb. That was a very succinct presentation. Remarkable that you could describe such a complex program in such a short time in such a succinct way. It's not every day we hear somebody talk about 100 millions of children and at the same time talking about threefold increases in the numbers of children reached. It really is a quite exceptional program, and remarkable too that it's run by all the individual states. And remember, some of the states in India are bigger than many countries. I mean, if you think of UP with its 200 million plus population, the government of that state alone has a greater challenge than some national governments. And that all of those states come together within one federal program where you can be given a summary of the monitoring and the evaluation outcomes. That's really quite remarkable, and thank you so much for that. And we'll have questions, if there are any questions for Dr. Deb, we'll take in the panel discussion right at the end. And part of understanding that great richness across India is, of course, the task of our next presenter, Dr. C.S. Agarwal, the head of the Department of Parasitic Diseases at the National Center for Disease Control, NCDC, as commonly known in India. Dr. Agarwal is a terrific colleague in all of this and leads the NCD task force that assists the national program, although Dr. Agarwal's background actually covers many other areas and worked in his time in epidemiology and malaria and environmental and occupational health, for example. But he's now going to talk to us about the creation of a map for across India on SDH and the challenges that he faced in pulling that together and working with WHO and other international partners to make that possible. So Dr. Agarwal, please. Thank you.
Thank you, Don. I'll share my. Thank you, Don. National Center for Disease Control is a nodal agency for mapping soil transmitted helminthiasis across the whole of India. Accurate estimation of epidemiological data is important to select the most appropriate intervention and to follow up impact of control measures. Information on control intervention in the past is important to interpret the present prevalence value, as the metrics of intervention are different for untreated population and as compared to treated population. Apart from measuring prevalence, STH surveys measure intensity of infection in terms of X per gram of feces, which are categorized as light, moderate, and heavy intensity, which are different thresholds for different worms. While planning rollout of nationwide deworming program in the year 2014, it was realized that sanitation and population density data of the country indicated that most of the children were probably in need of treatment that map of historical data and intervention information can drastically reduce need for collection of new data. That data collection should not delay implementation of control measures. It was thus decided to immediately develop a baseline predictive STH prevalence map and separately plan regular STH surveys. In this regard, contributions of WHO headquarters is gratefully acknowledged for developing this baseline predictive STH mapping. For developing a predictive map, following data was used: historical epidemiological data, ecological data, population density, and sanitation data. Historical epidemiological data was categorized into low, moderate, and heavy prevalence and was placed on the map based on available information. Ecological data in terms of annual precipitation, mean soil pH, mean annual temperature was also used in developing this predictive map. Population density data and sanitation data was also used for developing this baseline predictive STH prevalence map. This is a baseline predictive STH prevalence map prepared by WHO, wherein this green shaded area represent low prevalence of STH, that is below 20%. Yellow area indicate moderate prevalence, that is 20 to 50%. And red shaded area indicate high prevalence, that is more than 50% prevalence of STH. After this, for developing a regular STH survey for a vast country like India was a difficult proposition. For a sentinel school-based surveillance system was adopted, which was recommended by WHO. Sentinel survey system is a sentinel site-based periodic collection of parasitological data, which is assumed to be reflective of changes in prevalence and intensity of STH in the entire area. Sentinel sites are located in each homogeneous ecological zones. Number of sentinel sites is proportional to the number of school children living in each zone. PPS cluster sampling technique is used for identifying sentinel sites. One sentinel site is identified for every 200 to 300 targeted children. 50 children aged 9 to 11 years are covered in each sentinel site. This specific age group is selected because it has been observed in literature that this age group has the maximum intensity of infection for all the 3 targeted worms. Thus, we are in a way assessing the worst case scenario. Secondly, by using this standardized age group, our study becomes comparable for similar other studies. This allows estimates to be obtained with an absolute precision of 5% and a confidence level of 95%, which is sufficient for monitoring purposes. And it keeps the total cost of monitoring process to under 10% of the total project cost. Sentinel sites are selected by stratified sampling method, and to avoid bias, 50% of schools are proposed to be changed in each repeat survey. This is the location and number of sentinel sites selected with assistance of WHO headquarters, distributed countrywide. A total of 150 sentinel sites were selected, 98 in non-lymphatic area and 52 in lymphatic filariasis area. Lymphatic filariasis area was sampled separately. As you know, the treatment intervention in lymphatic filariasis area in terms of mass drug administration of albendazole will have an influence on prevalence value. Stool sample was collected from the school at the school level. Field teams were constituted. Each team composed of one public health specialist, a senior experienced microscopist, and 2 to 3 trained microscopists. The team went to each school twice. On day 1, purpose of the study was explained to the teachers and students. Each student was given a unique ID, and a structure pro forma was filled up for each student. Each student was given a stool sample container in a Ziploc plastic bag. And method of collection of stool sample by built-in stick was explained to the students. Second day morning, the team collected the stool specimens from the school and examined all the specimens on the same day by setting up a field laboratory in the nearest health care facility. Cartocat's technique was used for microscopic examination, and WHO standard template was used for measuring 41.7 milligram of stool sample. Microscopic examination was performed within 1 hour of slide preparation. Presence of helminthic X and count was recorded, and worm-wise prevalence and intensity of infection was calculated. Microscopists were trained and periodically retrained. For quality assurance, senior experienced microscopists in the team re-examined all 10% of the slides irrespective of diagnosis. This is the survey timelines. Baseline survey was conducted between December 2014 to February 2017. First repeat surveys started in the year 2018, August 2018. 14 states have been covered so far. Surveys have been got interrupted because of this COVID-19 pandemic. These are the baseline survey results. This is the baseline prevalence map of the country, wherein red shaded area indicates high prevalence, that is more than 50% prevalence, seen in 15 states. Yellow colored area is a moderate prevalence states, 19 states with prevalence between 20 to 50%. Green shaded area, these are 2 states represent low prevalence, that is below 20%. This is the ecological map of the country, displaying 10 ecological zones and a number of dots. Each dot is a sentinel site, which is geo-placed on the map. Green dots indicate low prevalence, that is below 20%. Yellow dots indicate moderate prevalence, that is 20 to 50%. And red dots indicate high prevalence, that is more than 50%. This is the prevalence of any STH in high prevalence state, total 15 states. The prevalence varies from around 50% in Manipur and Assam to almost 80 to 85% in Sikkim and Tamil Nadu. This is the worm-wise prevalence in these high prevalence states. It was mostly Ascariasis. Hookworm infestation was observed in 10 states, with prevalence uniformly below 10% in all these 15 states, except one, that is Uttar Pradesh. Trichuris was observed in 12 states. Again, the prevalence was uniformly below 10%, except in one island territory of Lakshadweep, where surprisingly, Trichuris was observed at the level of 63%. This is the prevalence of any STH in moderate to low prevalence state. These are a total of 21 states. Prevalence varying from 12% in Madhya Pradesh to almost 49% in Karnataka and Meghalaya. This is the worm-wise prevalence among moderate to low prevalence states. Again, it is mostly Ascariasis. Hookworm infestation was observed in 12 of these out of these 21 states, which was uniformly below 10% prevalence, except the state of Bihar. Trichuris was observed in 15 states out of these 21 states. Again, the prevalence of Trichuris was below 10% in all the states, excepting the state of Meghalaya. This gives the intensity of STH in terms of X per gram of feces, which is categorized into light, moderate, and heavy intensity infection. Mostly light intensity infection was observed in most of these states. Only in these 9 states, moderate to heavy intensity STH was observed. And here, as we see, Hookworm infestation above the level of 2% prevalence for moderate to heavy intensity was observed only in one state, that is Telangana. And Ascariasis prevalence of more than 2% moderate to heavy intensity infection was observed in 4 states. Prevalence of STH was studied for LF and non-LF states separately. Repeat surveys were initiated in the year August 2018. Surveys are planned and conducted just before start of the next deworming round. And sentinel sites covered in the baseline survey are taken up first in the repeat survey. These are the 14 states which have been covered in the resurvey so far. These are the various institutes which are helping us in STH mapping in the country. We are guided by the Child Health Division of the Ministry of Health and Family Welfare, and Evidence Action, the technical NGO partner of the Ministry of Health and Family Welfare, 3 ICMR institutions, 1 PGI Chandigarh, and of course, general support from WHO and other donors. Apart from this STH mapping, National Center for Disease Control conducts efficacy studies for albendazole and prevalence intensity studies for helminthiasis among pregnant women. And NCDC is also exploring newer diagnostic techniques for STH like mini flow-tech and qPCR. Thank you very much.
So thank you very much, Dr. Agarwal, for that clear presentation. Glad you finished on a note of pointing out that the National Center for Disease Control also is looking at other aspects of STH, and particularly the work you're currently doing on infection in women of reproductive age, showing that India is taking this very broad view of STH control and perceiving STH as a challenge in a number of areas. You showed how mapping 1 billion people is really a challenge, and how modern technology can really help with that. There's the use of ecological zones to target and examine the situation across geographies, and the use of remote sensing technology with that, and the work that's widely reported from your team with WHO in that area. And of course, the results are very convincing about the need for the national program. They show the very widespread challenge, but they also interestingly show how the challenge is very much around Ascaris, and perhaps that suggests it's a challenge that can really be met, and that targeting school children in particular makes good sense in this population. Well, thank you very much, Dr. Agarwal, and there'll be room again for questions right at the end to Dr. Agarwal, so please send those in. That would be very helpful. We've talked now, we've learned now about the pattern of disease, the pattern of infection in India. Now we're going to be looking at Dr. Manoj Merkar's presentation on the impact of those in infection. Dr. Manoj is the director of the National Institute of Epidemiology in Chennai, which is one of the Indian Council of Medical Research, the ICMR, one of their prominent institutions that oversees epidemiology in the broad sense across India. Again, a really daunting, a huge task. Dr. Manoj works on many disease areas, vaccine preventable diseases, outbreaks, and so forth, as well as leading on this STH area. He is a well-known academic, well-published academic and associate editor in a number of journals, and also advises WHO in their regional office. I want to thank Dr. Manoj particularly for giving his time during the COVID epidemic, because as you can perhaps guess, the National Institute of Epidemiology is also very actively involved in that. So I'm going to hand over to you, Dr. Manoj, to talk about the extensive reductions in STH in large school-based impact assessments in several states of India. Thank you.
Thank you very much, Don. Can you see my presentation?
Yes.
Yeah. So thank you once again. And I will be talking about our experiences about reduction in soil transmitted helminth prevalence in 7 Indian states. My colleagues have already mentioned about the burden of soil transmitted helminths in India, so I won't really spend much time on that. But just one point which I want to make is that traditionally the deworming programs were based mainly in schools, mainly because of the feasibility of such operations. And for such programs, the school-based programs, it is very important to have a reliable estimate of prevalence, primarily to determine the periodicity of deworming. Another important thing is that besides school-age children, other population cohorts may act as a reservoir of STH infection, and therefore deworming school children alone might not be able to achieve programmatic endpoints, might not be able to achieve the desired reduction in prevalence. So, during 2014 and 16, we conducted surveys in 7 Indian states to map the problem of STH. And the objectives of these surveys were to estimate the prevalence and intensity of soil transmitted helminths among school-age children. And the surveys were designed to have an estimate at the state level. The 7 states which were surveyed at the baseline included Bihar, Chhattisgarh, Himachal Pradesh, Madhya Pradesh, Rajasthan, Telangana, and Tripura. And these surveys were basically a partnership between state governments, especially the state health and education department. The evidence action was responsible for overall implementation of these surveys and also quality assurance. The National Institute of Epidemiology designed these surveys. We analyzed this data and finally generated the report. Whereas National Institute of Cholera and Enteric Diseases based in Kolkata and Postgraduate Institute of Medical Education and Research in Chandigarh, they were the lab partners, while the field implementation of these surveys was done by GFK mode. Very briefly about the methodology of these surveys. These surveys, as I mentioned, were school-based surveys, were cross-sectional in nature, and used cluster sampling. And for sampling, as Dr. Agrawal mentioned, we adopted a sentinel school approach. So sentinel schools were selected from each agroclimatic zone in the state, and the surveys were designed to arrive at the estimate at the state level. The stool samples were collected from children from their households, and they were examined using cart-to-cart method. And the data were analyzed to estimate the prevalence as well as to know the intensity of infection. And this table basically shows the 7 states, different agroclimatic zones in those states, the number of schools that were selected, and the number of school children that were sampled ultimately in the survey. This slide describes the prevalence of the weighted prevalence of soil transmitted helminths in different Indian states during 2014 and 16. And as you can see from this graph, the prevalence ranged from 12% in Madhya Pradesh to about 75% in Chhattisgarh. At least in 4 Indian states, that is Bihar, Tripura, Telangana, and Chhattisgarh, the prevalence of any STH infection was 35% or excess of 35%. Most of the infections were mild in intensity, and Ascaris was the commonest worm detected in all the states. Dr. Dev talked about National Deworming Days, so again I am not going to talk about that. But one point is that these deworming programs cover three important risk groups, that is preschool children, school-age children, as well as adolescents. And this slide basically shows the coverage of NDDs in 7 states where we did the baseline survey. And this is basically a reported coverage reported by the program. And as you can see, the reported coverage was fairly high, in excess of 80% in all the 5 years. In several states, the coverage was independently validated, and it was also found to be consistently high. And Dr. Agrawal mentioned, several districts in at least 5 of the 7 states that we surveyed, they are endemic for lymphatic filariasis, and where LFMDAs are ongoing. So since there was a very high reported coverage for 4 or 5 years, we thought of repeating the STH prevalence surveys, and accordingly we repeated these surveys during 2018 and 19 in 7 states. Here we followed 2 approaches for estimating the prevalence, or basically for sampling. The first approach was a school-based approach, or school-based sampling, where we selected children aged 5 to 12 years. And the school-based approach of survey were used in, or were followed in 3 states, that is Bihar, Madhya Pradesh, and Rajasthan. Whereas in the remaining 4 states, we adopted a community-based selection of cohorts, and we selected 3 cohorts, 3 age cohorts primarily. First is preschool children, that is children aged between 1 to 4 years. Second is school age cohort, children between 5 to 12 years, and adolescent, that is 13 to 19 years. So this slide summarizes the sampling scheme that was followed for school-based surveys as well as community-based surveys. Coming first to the school-based surveys, from each state, basically the state was divided into different agroclimatic zones. And from each agroclimatic zone, we selected the required number of districts by simple random sampling. And from each of the selected districts, we selected number of schools by population proportion to the size of the school. And from each of the selected school, we selected 1 class randomly, and all children in that class were selected. And these children were then contacted at their households, and the school samples as well as data were collected from their households. Coming to the sampling scheme for community-based surveys, here again, the state was divided into agroclimatic zones, and the districts were selected randomly from each agroclimatic zone. From selected districts, then we selected wards in case of urban areas, or villages in case of rural areas by population proportion to size. And then from the selected ward or village, we selected 1 census enumeration block randomly. Census enumeration block is essentially an area which is assigned to a school teacher for enumeration during a decennial census. And after selecting this census enumeration block randomly, the entire CEB was enumerated to find out the total number of preschool children, the school-age children, and adolescents. And from this sampling frame, the required number of preschool children, school-age children, and adolescents were selected by simple random sampling. So this slide basically describes the sample size that was used or that was required for surveys in different states. And the first 4 states are basically where we did community-based sampling. And the basis for sampling was 1 sentinel site, that is 1 village or 1 ward for 250,000 population. Whereas in Bihar, Madhya Pradesh, and Rajasthan, we adopted school-based sampling, and there we selected 1 school for 200,000 population. So this the last column basically shows the sample size that is required, taking into account the refusal rate. So sample size required for survey in different states range from 942 in Himachal Pradesh to about 4,152 in the state of Bihar. This slide describes briefly about the survey procedures. So we obtained written informed consent from the parents of the children, as well as assent from the children. And after obtaining this consent, we collected information about socio-demographic detail, as well as water, sanitation, and hygiene data. Stool samples were collected from the children. Early morning sample was collected. It was transported to the labs, which were specifically established at the district level. And we followed a double cartocards method. 2 slides were prepared from each sample, and the slides were examined independently by 2 trained parasitologists. I also want to highlight here the quality assurance procedure that was adopted during these surveys. The lab parasitologists as well as field teams underwent training before the survey. And for lab procedures, the duplicate slides were read by independent microscopists. And in addition to that, 10% of the slides were checked by an independent supervisor external to this study. For field operation, monitoring visits were conducted by Evidence Action as well as National Institute of Epidemiology team, and they followed the adherence to the survey protocol using a checklist. So this slide basically shows the prevalence of any SPH at the baseline and follow-up survey. I'm only going to showing the data of 3 states because the details of the results in remaining states are under discussion with HLSC. So as you can see, the data of these 3 states, the prevalence in Chhattisgarh declined from 75% to 13.9% in about 4 years of after the survey. Similarly, in Rajasthan, the decline was from 21% to 7%, and in Madhya Pradesh, the decline was 12% to 3%. So in the remaining 4 states, we observed a similar decline. The decline was observed for all types of SPH and in all age groups. And just to show you some data, I mean, the first 2 tables basically show the prevalence, the reduction in prevalence by the type of helminth, whereas the last table, the lowest table, basically shows the reduction in the prevalence by age group. So, what do we take from these the findings of this survey? There was a significant reduction in SPH, overall SPH prevalence in all the states, and we feel that this reduction was true in nature, was real in nature, and it was not because of any systematic error, either in selecting the individuals for the survey or because of lab procedure, for following reasons. First is that the sampling frame that was used for the baseline as well as follow-up surveys ensured representativeness of the sites from all the zones. And we also had a fairly good field supervision mechanism, and we ensured that the survey teams followed the survey protocol. With respect to lab procedure, we follow the same survey procedure, that is double slide cartocard smear technique in baseline as well as follow-up surveys. All the parasitologists underwent a 7-day training at the two labs, that is PGI Chandigarh and NICET Kolkata, and they were and their performance was evaluated and they passed the performance. And third point is we also had a fairly good external quality control mechanism, and an independent reviewer read all the slides. So we therefore don't feel that this reduction was because of systematic error, and we feel that the reduction was real in nature. The reduction in prevalence could be because of improvement in socioeconomic levels or wash indicators. And our data indicate a significant increase in wash indicators, especially proportion of children washing the hands between between the baseline and follow-up surveys, as well as proportion of households having their own toilets. Very significantly, as Dr. Dev mentioned, in 2014, Government of India launched Swachh Bharat, that is Clean India mission. And the aim of this mission is to eliminate open defecation and improve solid waste management. And as a part of this mission, annual surveys are conducted to find out the progress of each state towards the overall goal of eliminating open defecation and improving solid waste management. And the data consistently show improvement in wash indicators in 7 states that we serve. So yes, the reduction could be because of improvement in wash indicators as well as socioeconomic data. And the main reason which we feel is for reduction in prevalence is high coverage of MDAs in last 4 to 5 years. And as I mentioned, this coverage was not only high based on programmatic data, it was also independently evaluated. And the independent evaluation indicated high coverage of MDA. And besides that, several of the districts in 5 states, they are LF endemic, endemic for lymphatic filariasis. And LF MDAs are ongoing in these states. So I just want to conclude by basically giving mentioning 2 points. The reduction in the prevalence between baseline and follow-up surveys warrant a need for revising our treatment frequency from biannual to annual. But the important operational question is, how do we do it without the risk of resurgence of or increase in prevalence? And second important operational question is that at least in sub-state, there was sub-state differences. Within the state, there was a difference in prevalence. And how can we use novel or more decentralized surveying and treatment approaches in such situations? And especially if the prevalence is very low, how do we approach surveying in areas where prevalence is extremely low? So thank you very much, and I will be happy to have any questions.
Thank you very much, Dr. Manoj. That's a great presentation and followed on very nicely, I think, from Dr. Agarwal's presentation in filling in the next step in the question, which is, that's the prevalence we used to see. What's happening today? What's been the impact of these programs? And I was very impressed, particularly about how there were multiple partners involved in working in different areas and different geographies, but engaged around a common methodology. And you explained very clearly there the importance of confirming that the coverage was good, that the deworming intervention itself had been delivered in the way that was intended, that the coverage was strikingly effective, strikingly high in those areas that you followed up on. And also that you experimented with different survey methodologies to ensure you had real confidence in the reduction. You left us with a very tantalizing question as to what was the cause of the reduction. Certainly, it looks like the deworming coverage was good, and that those interventions were all in place. But you're also mentioning this other extraordinary program in India, again, an enormous public health program, Swachh Bharat, the Clean India program, that has also undoubtedly had a role to play. And I know that the team is all working together in further analyses to uncover the details of this. So thank you. An example, I think, of what's increasingly called precision public health, the clear analysis that leaves one confident in the credibility of the results. And that's a great segue to our next presentation, which is going to be given to us by Ms. Priya Jha, who is the Evidence Actions Country Director for India. Priya leads the development and execution of Evidence Actions Country Strategy for India, providing both technical and managerial oversight to those initiatives. And really looking at expanding Evidence Action's portfolio of in-country evidence-based innovations to and in this case, particularly drawing lessons from this successful at-scale deworming program. Ms. Jha has been, had worked previously with the Ministry of Health and Family Welfare, with the World Health Organization, with Plan International and the United Nations Population Fund, and is now going to give us a presentation about evaluating the feasibility and cost effectiveness of conducting community-based surveys of STH. Thank you very much.
Thank you, Professor Bundy. So I'll just share my screen here. Right. Very good afternoon to everyone from India. Particularly thanks to the COR-NTD Secretariat, Professor Bundy, to the co-panelists and all participants at the session. Before I even begin with my presentation, I would like to take this opportunity to thank Susie, who was leading this session, and unfortunately is not here today. And I hope I can fill her shoes in presenting this session. And to thank the Government of India and the state governments for their leadership and commitment behind this program. I've been associated with this since 2013, and I've seen the relentless efforts and commitment that Dr. Dev's office has put into the program, to all the state governments, to partners like NCDC, NIE, and others who are not here at this point, but have really contributed to this mammoth effort. Also not to miss acknowledging and expressing my gratitude to the donors who have stood behind Evidence Action and our technical assistance to the Government of India and this mammoth effort, in particular the Children's Investment Fund Foundation, N-Fund, GiveWell, the Benham Family Foundation, Dubai Cares, and others who have really been a pillar of support for this effort. So thank you to, and our gratitude to all our partners and donors. So taking my presentation forward, I will be sharing it's a good segue from what Dr. Manoj has just presented about the community-based surveys that were conducted in 4 states. We piloted with Chhattisgarh and Himachal, and then to understand the process a little more, conducted a similar community-based expanded cohort surveys in the states of Telangana and Tripura. For all of us who are on this, are listening into, we are aware that this the program, the deworming program, the MDAs, the school-based program, really have been targeting school-age population for the longest period, while the WHO's revised methodology or guidance came in 2017, included further at-risk, expanded the cohort of at-risk population to include preschool and women of reproductive age. Interestingly, the Government of India, when adopted the National Deworming Day program way back in 2015, already had an expanded cohort that they were reaching out, which is 1 year to 19 years. And that was a significant population that they were covering, and which in some ways sort of preempted our thinking about looking at expanded cohorts for prevalence surveying. And we realized that there was no standardized protocol available to survey these other cohorts. And so while WHO guidance was available for surveying among SAC, the school-age children, it wasn't available for the expanded cohort, even though the guidance does include those, and the Government of India had been implementing the program for the longest while. Evidence Action, in collaboration with the national and international partners, developed this methodology of surveying the expanded cohort, and were at the same time measuring the cost, looking at the feasibility of conducting these to see if it was even possible or feasible to have a wider rollout as part of the larger STH roadmap efforts that were being envisaged through the high-level scientific committee. So this methodology, when was conceptualized and put together, was placed before the high-level scientific committee, and with approvals from Government of India, we further went to the specific state governments and other stakeholders, and approvals were sought, and they were continued to be updated on the progress that we made and the findings that we had. In terms of, I've already sort of shared some context to the expanded cohort. What was important for Evidence Action and partners at this point of time was, one, of course, to look at the cost effectiveness, but also to determine if school-age children are a suitable proxy or expanded cohort prevalence for state decision making. And to inform not just the Deworming program of India, but also share findings and learnings with the larger global community as the expanded cohorts will continue to start receiving more treatments with the new guidelines from the WHO. So the secondary aims, so to say, was, of course, to measure the changes in prevalence and intensity of STH among the school-age children. This was the common age group that were surveyed at the time of baseline, and these were the follow-up surveys that we were conducting. As Dr. Agarwal and Dr. Manoj mentioned, the objective was also to update the maps, enable improved decision-making regarding future surveying and treatment frequencies or strategies if needed to be revised. And I think both our earlier panelists talked about both state level and sub-state or the district level programming that might be needed as prevalence rates dropped over a period of time, including drop in intensity. So this methodology was firstly introduced in Chhattisgarh and Himachal Pradesh. And a brief comparison of the methodology between the school-age population and the expanded cohort was one that we did not have a WHO guidance for expanded cohort, and so we were learning, and we were taking guidance and advice from experts as this was being developed. The sample size, I think Dr. Manoj as well alluded to in his presentation, was looking at a village instead of a school or a census enumeration block per 200 to 300,000 target population of preschool age, school age, and adolescents by the ecological zone. The rapid village mapping was conducted to demarcate the boundaries, and enumeration of household with the house listing and individuals per cohort were also listed by the field agency. And then children were randomly selected from the enumeration list as would have been as was being done for the school-based surveys. The samples were taken. The stool samples were taken, collected from the homes. The Cato-CATS method was used, and questionnaire collecting data around wash and other risk factors were applied, just as it was done for the school-age population methodology. In terms of the timing and frequency, the survey was done prior to the school-based deworming. So the National Deworming Day is something that is a fixed single day program, and in consultation with the government, with the respective state governments, the planning for the surveying, the follow-up surveying was done. And Dr. Manoj talked about the quality assurance. There were very stringent measures that were put in place. And one additional point I would like to mention was there was a lot of emphasis that we put on getting real-time, literally daily feedback was being provided by the quality assurance people out at the field to make sure that any corrective actions, if needed, were done right away. And so that communication was very critical to the process. The partners, again, were the National Institute of Epidemiology, PGI Chandigarh, NICE in Kolkata. We were NCDC, their team members also visited some of the sites. We had international experts and others. In fact, even the state governments visited, and participated in the survey as part of the learning and sharing process, and the ethical approvals as appropriate were taken for the study. Um, Dr. Manoj has already shared the samples. I'm just sort of, again, just briefly only referring to Chhattisgarh at this point of time. Here, what I'm sharing is in particular would be of interest, but the sample size at the time of baseline through a school-based methodology was nearing about 1,500, which in an expanded cohort increased to more than 3,000. The number of sites, as Dr. Agarwal and Dr. Manoj mentioned, for the follow-up surveys included 50% sites of the previous survey, which was the baseline survey conducted in 2015. And the number of districts covered under any of these two surveys was between 13 at baseline and 11 at follow-up. Chhattisgarh has 27 districts there are 27 districts in the state. In terms of the analysis around feasibility and cost, we would say that the methodology was well implemented. We were successfully able to achieve the sample sizes that we set out for. The quality assurance procedures were well followed, documented. There were no irregularities that we found. There was great coordination. All partners were informed at all times, and we can clearly say that it was the expanded cohort communities methodology was well implemented. In terms of costs, we compared similar states. So we had Chhattisgarh, for example, we did baseline and follow-up. So we were able to compare the cost. Our cost analysis tells us that the expanded cohorts were about 1.6 to 1.7 times higher from the school age, the school-based survey methodology. And that's overall, but on a per site basis, the expanded cohort survey cost anything between 2.4 to 3.8 times higher. So definitely cost was something that we saw, even though the sample sizes, while the sample sizes were more, and the number of sites were more, the cost surely did show a definite increase. In terms of analysis of data, we found that there was no statistical difference in the burden found among the three age groups, with the school age and children population could very well be taken as a suitable proxy for other cohorts. From a program level decision making, we found that the expanded cohort surveying presented limited additional information. The information gained on risk factors, which is mostly around wash indicators with infection, was found in one of the states. The expanded cohort surveys from our analysis could be definitely add value while we are refining treatment strategy at, specifically looking at a particular cohort, or if there are operational research questions, but in terms of a program at scale, they may perhaps not necessarily address any additional information than what the school survey did. There was secondary, in terms of the knowledge gain, we did find increased information around wash indicators. The details are available. What we could from our detailed analysis of wash indicators, what we can surely say that the findings enhance the case for building in additional targeted hygiene messaging within the programs. So while continued efforts from the national government and state governments in terms of participation and collaboration with the Swachh Bharat mission has existed, we surely see that there could be a case for building more targeted hygiene messaging within the program, and perhaps looking at any operational research questions within a particular state to ascertain what are the most effective platforms for these messaging, as there were definitely areas that we think there could be additional information that would be helpful. The feasibility and acceptability for the expanded cohort, from our experiences of conducting both kinds, we were able to clearly state that planning for a community-based survey with an expanded cohort required a lot more lead time. So there were right from gathering the CEBs, the census enumeration block maps, to working with the identified the selected communities, the villages. That required more lead time. There was community awareness that needed to be done, and engaging with more localized village level leadership was also something that took some additional lead time, which was not necessarily our experience for school-based programs, because these were identified schools. There were letters that we got from the Department of Education, so it allowed there was ease of entering into the schools, and getting the information to begin with was comparatively faster as compared to the expanded cohort in the community. Even convincing parents and guardians took again a little more time, because you had all the expanded cohort. So for preschool age children, the really younger children, engagement of parents and guardians became so much more, from the explanation of why to how to collect the stool samples. Their engagement and their involvement was more intensive. And so additional time and efforts were required. What we also realized more so in the expanded cohort survey was that female surveyors became essential when we were reaching out to the adolescent population, specifically the adolescent girls. That was not something that we had observed in our school-based methodology, perhaps because we went through schools and the teacher was also involved, and this was more direct conversations with adolescent girls. So having female surveyors was important. IEC materials had to be brought in for adolescent groups, because they needed to be interperson communication with them around the survey. We were able to, while we were able to achieve the pot return rates across all cohorts, for the younger children, for the preschool age children, we had some difficulty, because, as I mentioned, engaging with parents became more important, and as not much with the child themselves. Dr. Manoj and Dr. Agarwal talked about the labs, and while we did contemplate setting up labs at the community level itself, but the weather, the accessibility issues, power supplies were not in favor, and we had to set them up at the nearest health center. So traveling with the pots in time were also something that added to the complexity of it. The slide throughput challenges were also seen, though we were, again, like I said, we were able to achieve all the targets. It took us more time. There were days when we did not have enough, and then there were days when we had more. And then we could not leave a particular village till we had not achieved the size, the sample that was required. So sometimes there were incidents where we had to spend an additional day or two in a particular community to ensure that we were getting the sample size. So that also led to some difficulties in terms of logistics, and planning sometimes went a little haywire, and it led to increase in cost. But eventually we were all able to meet the targets, and I think those were important as well, the targets for the samples. So weighing all the cost and benefits, our recommendations that was made to the HLSC was that the expanded cohort was found to be not the most cost-effective methods in the states that we did this, and likely it would not be the case for national surveying. The high-level scientific committee deliberated on the findings, and they recognized all the benefits and challenges for both the survey methodologies, and they recommended to the government of India that the school-based approach would be used for future prevalence and intensity surveys. And the results are statistically similar and cost-effective, which is why we should continue with that. Additionally, any required value for expanded cohort could be taken on a case-by-case basis, depending on any specific operational research question that did arise. They could be taken up. So carrying on with some of the key operational questions that we continue to have. Some of these have already been touched upon by earlier panelists. I would sort of, just sort of reiterate on alternate diagnostics. I think that's something that perhaps has not been touched upon in low prevalence geographies, as we're seeing that, as you would have seen from Dr. Manoj's slide, we are reaching, really low prevalence in certain geographies. And then what are the kind of alternate diagnostics that are going to be, again, cost effective, feasible, to be, easy to implement at scale, that India should be considering, the government of India should be considering over the next 3 years to 5 years. I think that's something that we must be looking at and seeking sort of hearing from partners and experts from across the world, and the methodology that we must also adopt, again, for both at scale for a country like India, in light of the low prevalence, low intensity infections that we are starting to see with more than 5 years about of the deworming program. So that as well would be a question that as the team that supports the program of the government of India, what are those that are going to be answered? Yes, thank you so much, and happy to take any questions. And again, thank you for the patient hearing and the opportunity.
Great, thank you so much. So much, Priya. That's excellent, very clear presentation that gives us the very important message that information is not free, and that increasing precision often implies greater cost. And so that's a great way of laying out. I mean, I think this is the sort of hallmark of evidence actions kind of work, isn't it? The operational research to really assess the trade-offs between doing more intensive surveys and being able to do more surveys and more frequent surveys. So I think that's a great way to move us into the question and answer session, with which we'll finish off our conversations today. And we've had quite a lot of chat coming in during those presentations. I'm going to just say to our audience, thank you so much for your kind words about the presentations. The 4 presenters really did do an excellent job, and thank you for pointing that out. But let's ask a couple of questions. I'm going to turn first to Dr. Agarwal, although I know you've been on the chat yourself in the background, but let's just take this question. This was one that came in from Sitara, and there was some follow-up to it. Is it time to plan more sensitive and more cost-effective molecular assays? So this is, I think, a reflection on the focus on using CATO-CATs and other coprological techniques. Dr. Agarwal, would you?
Yeah, thank you, Don. This is just to say that CATO-CATs is a time-tested technique which is very much applicable for field surveys. Studies have shown that CATO-CATs retains a high level of sensitivity even at low prevalence of STH. Only when we go to very low prevalences, then molecular techniques perhaps have a value. Or maybe molecular techniques have a value in efficacy studies or in studying markers of evolving resistance. We are in the process of developing our capability in molecular techniques, but CATO-CATs remains a time-tested strategy for school-based surveys or community-based surveys for soil-transmitted helminths. Thank you.
Okay, thank you so much, Dr. Agarwal. With these questions, if there are others that wanted to come in on them, please do so. These questions, I'm going to try and direct them to particular panelists, but the whole panel is, of course, most welcome. And can I ask, actually, Dr. Deb and Ms. Priya Jha, if you could start up your videos as well, so we can have you all on screen during this phase, that would be great. So I'm going to a related question then is one from Rubina Imtiaz to Dr. Manoj, which was a question around the use of community versus school-based sampling. And so this relates to CATO-CAT, the difficulty of sometimes of obtaining material. Did you find a difference in your sample response rate between the school-based way versus the community way?
Yes, in fact, I responded to Rubina privately. There was a difference in response rate. I don't have the rates readily available, but community-based sampling had a low response as compared to school-based sampling. And especially in adolescents and adolescent girls, the response was lower, primarily because of the custom here. Women or the girls hesitate giving sample, and so that was the issue. And as Dr. Priya mentioned in the presentation, even the small, the preschool cohort, like 1 to 4 years, since their bowel habits are not very regular, and our team used to go to in the morning for collecting stool samples, so that also was an issue. So in that context, can we detect the SPH or SPH infection through a rectal swab using a molecular method? Maybe Dr. Sitara, if you could respond in the chat, or maybe Dr. Dawn, if you could advise us on this.
So Dr. Manoj, can I move on to some of the other questions? You know, we're the guys that are supposed to answer the questions, not ask them. So I'm going to carry on asking some of the questions that are coming in, and we can come back to discussion. I'm just conscious of time. So a very much a related question is one directed to Ms. Priya Jha, which is this one's come from Rajiv Saka. When you're considering the expansion of community surveys, do you think that you should also be looking at the adult population? What's your feeling there? That's, as I say, is to Priya, but of course anybody can answer it.
Sure, I can attempt, and perhaps Dr. Manoj can also add, because we did, when we were discussing the sampling methodology for expanded cohort, we did include women in reproductive age as one of the cohort, and we found one that, of course, the cost itself and the sample size just exploded in terms of the numbers that we would have had to cover. And then we had to make those decisions around cost, and also around the fact that the women in reproductive age were still not being dewormed as part of a regular program in the same level of sort of consistency and coverage as we were seeing with children and adolescents 1 to 19, because it's still a very nascent program for women in reproductive age. So at that point of time, when we were envisaging this methodology, this was dropped. But surely, as I said, one of the decisions that the HLSE has taken and recommended to the government is to look at different cohorts on a case-to-case basis, depending on an operational research question that we may have. I hope that answers. Dr. Manoj, anything that you would like to add?
No, I think you have answered it. Just to add, like in our surveys, the community-based surveys, we did not find any difference in the prevalence by age group in 3 cohorts, basically. So, and as Priya mentioned, adding additional, I mean, we didn't find difference in preschool, school age, as well as adolescent. So if you take these 3 cohorts, your cost increases by about 2.5 times. But instead of that, if you can take or include adults or women of reproductive age group, we will get data about the prevalence in these cohort, which then could be, we can start some program for pregnant women. That is worth considering, is what I feel.
Okay, well, related to that, a question from Armel Fora. We saw some differences in burdens. Are school-aged children a good proxy for measuring prevalence or intensity for all 3 species? That's the question. Does it work for all 3 species? I don't know whether that's you, Dr. Manoj, or Dr. Agarwal would care to take that question.
Maybe, See, at least in the 7 states that we surveyed, in all the 7 states, Ascaris was the predominant parasite. So maybe Dr. Agrawal, you mentioned that in some of, like in Lakshadweep, there was Pechurus and lukewarm in some states. So,
yes. These school-based surveys are very effective in measuring all the 3 worms. The problem is specific in case of hookworms. One thing is the hookworm eggs are very unstable. They hatch very fast. So samples have to be processed really fast. And even microscopy has to be done within 1 hour of slide preparation. And also in the hookworm, we see that with the increasing age, as we go in the adolescent and adult age group, the hookworm infection tends to remain at a high level. So, but more or less we have seen, studying from literature, this, if we are covering the school age children, especially 9 to 11-year-old age group, we can very well assess the prevalence and intensity of infection, and we can reflect it as that in the population. Dr. Manoj, would you like to add something, or still?
No, I
maybe
think you answered it. Yeah.
Mm-hmm.
Yes, thank you. I think you gave a good answer there. But so here's another question. This one's from Rajiv Sarkar. Any difference in infection between in-school children attending school, and children who are out of school? Was there any difference in levels of infection? Do we know anything about that?
Well, Dr. Sarkar, we really haven't, because we should have that data at least in community cohort, and we can look into that. We have not really examined that whether there was a difference in the prevalence by children who dropped out and who are in the school. We will look into it.
Sorry, somebody speaking there, was that a question? No. Well, related to these questions about the different species, Susan D'Souza asks the question: how common is Strongyloides stercoralis in these populations? The 4th most common of the STHs. Should there be some thinking about monitoring that, or including that in the thinking?
Actually, I've answered that in the chat box. We have very limited information, limited data on strongyloides in India. We need to plan exploratory studies to get an estimate of burden of strongyloides in India. Right now, we have very limited information on it.
Okay, thank you. That's great. And then a related question is about the focus on drugs, the focus on the use of albendazole in this program. And is there any, this is from Sandra Albert, any evidence of resistance to albendazole, particularly observed in hookworm or trichuris? Anybody like to address that question? Dr. Agarwal, I think you'd already given some response to that. Dr. Agarwal, perhaps you can't hear me anymore.
Can you just repeat the question?
Sorry, this is the question about, is there any evidence of resistance to albendazole in India, especially in hookworm and trichuris infections?
Yeah, actually, hookworm and trichuris prevalence is very low in our country. And that is why efficacy studies for hookworm and trichuris have not been conducted. And so far in literature also, the data is not that much available regarding resistance in hookworm and trichuris. And in the country, we have very low prevalence. So we'll not find sufficient sample for carrying out any studies. We have not carried out any efficacy studies for hookworm and treacherous.
Right, and for Ascaris, do you see any evidence of resistance?
Ascaris, so far, the studies we have conducted, no resistance has been detected for Ascariasis.
Okay, but that would be an NCDC is monitoring those issues. Would that be correct?
Yeah. Yes.
Great. Those are the questions that I managed to pick up from the chat that was coming in, but there are some other questions here. So, and this is one I'm going to actually, if I could ask Dr. Deb to relate to. This is, the NDD is the largest and most complex school-based deworming program in the world. What are them, if you were to be asked to give main messages learned? We've got a global audience here for this discussion. What would be the main messages that you would want to share with a global audience? And I'm going to go to each of the other three panelists and ask them that same question. What's the main message you'd say from this the extraordinarily NDD program?
So, very important question. So the messages that we understand from our experience for the last 5 years in implementation of this program. So one of the pillars of success for this program was the inclusive approach. For as it was saying that it is a unique convergence strategy that had been developed into the program for working with the other ministries, the other departments, and the other partners, including all the partners. So this has actually strengthened this program with their participation, and with the leadership at the state levels, as well as the knowledge creating platforms. So this is this comprehensive approach needs to be continued, and this is actually a learning experience from this program. Then another thing is that there is the need for taking continuous feedback from the ground situation, and keeping our thoughts open to the newer developments in the program, and the newer thoughts that as we in the last discussions we had, it came up that what about the resistance, to the question on resistance, we have to think about it, and whether the other age groups, the women of reproductive age group, we are having a big problem of anemia in our country also. So whether how we can engage for the other age groups where we are now presently not focusing. So this is a very dynamic process and a very dynamic program. And for the successful implementation of the program, there is need for a continuous feedback also from the ground. Also for the program success, it is necessary how the different players at the ground level, they are energized and they are kept energized to be involved in the program proactively. Then there should have the provision for flexibility for local adaptation. So that we always encourage the states that you please come up with some innovative idea if you can in implementation of the program. So we are open to that. But however, we are also looking into the uniform and uniform implementation of the program, and strict guidance also, to strict adherence to the guidance which is being provided from the center. So at the same time, both flexibility for local adaptation but also sticking to the main principles of the program. And then monitoring and independent validation. that is also another important area. This is whatever we have now till now heard from the different partners of our program, the NCDC, National Center of Epidemiology, National Institute of Epidemiology and Evidence Action, and several other institutes. So they are always there for, and they are in different ways. This program is being monitored. It's monitored for this implementation, monitored for the prevalence surveys. So this is also is a complex process, but this is also very important, and this has added to the success of this program. And we are, as already I have also pointed out, that we always are we examining the data and examining to and we are actually advocating with the states every year for how how they can go for data driven programmatic improvements. So these are the components I think that has been added to the success of the program. Thank you.
Thank you very much indeed, Dr. Deb. So Dr. Deb's the boss of the program, so it's great to hear give those very clear guidelines, which we can come back to in a moment. What I'm going to say, because time is now getting a little short, is I'm going to ask each of you to just give one or two examples of the key messages as you see it. So I'm going to just ask you in the same order that you presented. So if I can go to Dr. Agarwal next, please. Dr. Agarwal, you're muted.
The planning and implementation of survey are really a very cumbersome exercise, and ensuring the quality is also very important in all these surveys. And even after collection the data, analyzing the data, interpreting the data meaningfully, conveying it for purpose of evidence-based policy decisions is also very, very crucial areas. Then monitoring various aspects of the program and updating the policy makers for timely programmatic changes is also important, like high-risk groups, like evolving efficacy issues. So those are the things we have to look into and guide the program so that mid-course correction can be done and we achieve our targets. That is how we are trying to endeavor. And we are also looking into various diagnostic technicalities, going into refined diagnostic technologies, sampling methodologies. And even after winning on these 3 targeted worms, how to expand, what are the other problems in our country, maybe going into other helminthic infections. And that's it. That will be.
Thank you.
Thank
you very much, Dr. Agarwal. That's great. Dr. Manoj.
Yeah, maybe a couple of points. First is that one message which I want to give is that extensive reductions in prevalence of SPH is possible with improvement in wash indicators as well as with sustained or very high coverage of NDD or MDA. So that is the first message I want to give. And second very important thing for the program is there is a need to have a good documentation of all the processes. So in case of NDD program, what proportion of children have received the tablet and how many of them have consumed? That data should routinely be collected, not through program, but maybe by an independent agency. I just want to give an example of a polio program. Like we also had a national immunization days where a large under 5 children, large proportion of them were used to receive polio vaccine. And following each round, there used to be an independent assessment, a rapid survey, to monitor, to know as to how much was the coverage. I mean, if that kind of process is also attached to this NDD administration as to how much was the coverage, how much was the compliance of drugs, it will be very good to monitor any impact of drugs. Thank you.
Excellent. Thank you very much, Dr. Manoj. And finally,
can I add one point?
Can I come back to you, Dr. Deb? I'm
Sure.
just going to ask Ms. Priya Jha to just give her comment, and then I'm going to come back you, Dr. Deb, to actually close off the session, if that's okay.
Thank you.
So
yeah, thanks, Don. And just to add to the great experiences shared by all the panelists, I would say that for a program at this scale, and having been associated with it from day one, I can say something that we were always on top of was the use of technology for scale. We really knew that if we had to reach the last village in the extreme northeast of India to the south of India, very diverse settings, very different priorities that the governments have. We needed to bring together the program, and using technology, common platforms, standardizing tools were going to be extremely important, so that we had timely data and we were analyzing them and informing the flexibility that Dr. Deb talked about. So I think that those were adopted very early on in the program for gathering coverage reporting, for gathering the prevalence survey data, the mapping, the MIS has been extensively used on the program. And I think that to me would be one key message as for programs to adopt more and more when they go to scale, and for also important to maintain the fact that we have done 10 rounds in 5 years. You have a program that's implemented at that scale and it's consistent. We have not missed a round. Even during the pandemic, we have not missed a round. So there's a lot of consistency that this program has, and that comes really from the fact that it's evidence-driven, it's data-driven. There is information available for every round within the next 2 months, 3 months, that helps inform policymakers to plan for the next one. So using technology, using data, I think is going to be extremely important and a key message for me.
That's fantastic. That's a great set of messages. I have to say, all of your messages are sub-messages of the ones that Dr. Deb started with, which is great. And let's write these up. Actually, let's bring this all together. So Dr. Deb's list was that we need energized partnerships. All the actors are properly involved. Continuous feedback from the grassroots and all the levels we should be hearing from. That there needs to be a balance between flexibility in local context and local innovation, but also balancing that with clear guidance. And that crucially overall, precision monitoring that provides, that involves all the actors in the partnerships. So Dr. Deb, would you like to leave us a final word from
Yes.
the session?
Yes, just I wanted to add one point that I saw in the chat that there was a question on regarding the out of school children, how to include them, and what is the bulk of the out of school children. So from the data we have, so in 2017 there was around 4% of children who were out of school, and in 2018 we say that it is less than 3% is the number of the out of school children. So, but in numbers, actually, it will be a big number again, considering the total population of India. And so, so we have to address comprehensively for the target setting. Based on the census, and again for the different groups actually. So another thing that Dr. Manoj was saying that that was important, but I would like to clarify that these tablets in NDT program, these are being actually administered on the spot, not being given to the children to consume later on. So there is there may not be any thought that whether they have consumed or not. So this, because this is our core strategy, that the tablets has to be given on the spot at that time of administration. There has to be the healthcare provider as well as the either school teacher or the parents. So there is no confusion about that. That I wanted to clarify. And so I thank so much, my heartfelt thanks to the COR-NTD secretariat and Donald Bundy for excellent carrying out of this program as a moderator. And thanks to all the panelists So for excellent presentations, and I thought that today also now in this session we have gathered some more food for thought and for some more research issues which we will now concentrate for our next program, that is for the next 5-year program. Thank you, Dr. Conrad.
Well, thank you very much, Dr. Deb, and you've done my job for me. So it just remains for me, on behalf of all the global listeners to this this broadcast, to thank you, Dr. Sheila Deb, Dr. Agarwal, Dr. Manoj, and Ms. Priya Jha for really excellent discussion, a very interesting presentation about this extraordinary program. And clearly impact is happening. We want to read more about this as you start to publish these results in full. Thank you so much for such a fantastic contribution. And at this point, I pass over to Chelsea, who will turn us all off. Thank you.
Well, thank you again for that wonderful session from Dawn, our moderator, and from all 4 of our speakers. Thanks again to Evidence Action and the STH Coalition for organizing this wonderful session. On behalf of the COR-NTD Secretariat, I'd like to remind you all that there is one more meeting left in this STH series, so please do keep an eye out for that announcement, and I will be very pleased to follow up with the recording of this session with all of you. So wishing you a wonderful rest of your day and a fabulous weekend. Thanks, everyone.